Okay, I'm gonna spend a few minutes talking to you guys about drugs to treat blood disorders. And we're gonna start with anemia. Before we talk about how to treat anemia, I wanna just kind of talk a little bit about what it is. So, anemia is defined as below normal plasma hemoglobin concentration can be due to either a decrease in the number of circulating red blood cells specifically, or an abnormal amount of hemoglobin per unit of blood volume. So it can either be a decrease in blood cells or not enough hemoglobin per unit of blood volume. And there's some other versions of anemia as well. We'll kind of talk about that as well. In general, the signs and symptoms of anemia are probably the most common one is fatigue, unexplained fatigue. But as the anemia gets more and more advanced, you'll see other symptoms as well, like a rapid heart rate, a shortness of breath. The patient may be pale. They may get dizzy, especially when they go from a lying to sitting or a sitting to standing position, and they might also have insomnia. Another thing that I don't have on there, but I should have on there as well, is a pretty common symptom of anemia is restless leg syndrome. So that's part of why they're not sleeping. It's because they have this pain or they can't stop moving their legs at night, and that's one of the sort of common signs of anemia. So the reason why the heartbeat is rapid and the shortness of breath and all of that is, remember, the whole point of the red blood cell is to carry oxygen around, right? Oxygen delivery. And if somebody is anemic, and especially if it's due to not enough red blood cells, or that the cells that they have aren't able to carry as much oxygen because of some abnormality of hemoglobin, then the person's circulatory system is going to have to work harder to pump whatever oxygenated blood they have. So remember, we circulate is essentially our entire blood volume every minute. So if you're not able to deliver as much oxygen, then we have to kind of work harder and faster at that. So that's kind of where the rapid heart rate and the shortness of breath and the dizziness is more of a lack of oxygenated blood flow to the brain specifically. So there's lots of causes for anemia, and some of those potentials are some kind of chronic blood loss or an occult bleed that's not been detected. They can have bone marrow abnormalities. They can have something that's causing their blood cells to be lysed that can sometimes be related to drugs. So lots of drugs can do that. They can have chronic infection. Chronic infections are something that we don't oftentimes think about with anemia, but especially gastrointestinal infections. A lot of those microbes that are potentially overgrowing or are inhabiting the intestinal tract that shouldn't be there, bacteria need iron, right, to survive. And so what they essentially do is they are able to consume the iron from the food before it gets absorbed, and so these patients aren't able to store iron very well, which you would see on a ferritin test, and they also oftentimes have actual frank anemia. Early on, sometimes they'll just have low ferritin, and then it will actually progress to a frank anemia. Cancers can do it. Some of the endocrine deficiencies can do it. Renal failure can do it. Remember, the kidneys is where erythropoietin is secreted from, and erythropoietin is responsible for the manufacture of, or the release of, I guess we should say, the maturation and release of red blood cells from the bone marrow, from the red bone marrow. So people with kidney disease oftentimes are anemic. I mentioned drugs already. Alcoholism is another common cause of anemia, especially B12 and or folate anemia deficiency. Folic acid deficiency and B12 deficiency can also cause an anemia. It usually looks a little bit different than we see with iron deficiency anemia, or that anemia of just blood loss, decreased red count. But that can cause an anemia. Sickle cell anemia is another potential cause of anemia. Sickle cell anemia is an interesting disorder in which the red blood cells are abnormally shaped. Not all the time, but when they're abnormally shaped, they are kind of gobbled up by the spleen and they get taken out of circulation, and therefore the overall count can go down. And then it can be a little bit more simple with just a iron deficiency, put folic acid or B12 deficiency in the diet. You got to kind of watch carefully for with the folic acid and B12 situation. You want to look carefully at your vegan population and or maybe your vegetarians, but very definitely with the vegans. The vegans tend to have quite a few nutrient deficiencies, but one of which is these B vitamin deficiencies, because specifically B12, the source of B12 are animal products. So if somebody's not consuming animal products, they're likely going to be deficient in B12 if they're not supplementing. And you can see in that little box below, in addition to the signs and symptoms that I mentioned above, B12 deficiency causes oftentimes tingling in the hands and the feet, kind of like a neuropathy. Difficulty walking, and it can actually look like dementia, hallucinations, paranoia, and or schizophrenia. So it's not an uncommon deficiency, and it's something to think about, especially in some of these patients that might be exhibiting some of these signs. It's pretty easy to rule out, on a simple blood test. So in terms of treatment for anemia, the drugs are called the anti-anemic or hemopoietic drugs. Hemopoiesis means to build blood. So these drugs are going to essentially, hopefully, first you have to, before you can pick a drug to treat the anemia, you have to know why they have it. So once you make that determination, then you can select the correct agent. So if they have iron deficiency anemia, obviously you would need to give them iron. How that would look is their cells would really be very, very small under the microscope. So it's called microcytic anemia. Sometimes they're also very pale, and that would be called hypochromic. People that have B12 deficiency or folic acid deficiency, those are hard to tell the difference just based on lab. They have red blood cells that tend to be very big, so that's called macrocytic. You'd pick that up with an MCV, which is a mean corpuscular volume, just says the size of the red blood cell. And the reason why people with B12 deficiency and folic acid deficiency I should say, it's because that B12 is a really important coenzyme for the synthesis of DNA and other really important cell components. And folic acid actually you need for amino acid and DNA synthesis. So they're really important, and you also need, in that same vein, I should have kept going. You need you need these nutrients for adequate cell division. So essentially, what happens with these patients is the red blood cells just get bigger and bigger and bigger in the red bone marrow, and they don't actually split. So we just have these maybe not as many cells, and they're also very large. So if you knew that somebody had a B12 or a folic acid deficiency, and like I said, it's hard to be able to tell based on just symptoms. So oftentimes the recommendation is just to supplement both B12 and folic acid to correct that type of macrocytic anemia. If somebody's lost some blood, then you'd have to replace that. So you could give red blood cells or whole blood, depending. A drug called Epogen or darbepoetin. Sorry, it's a hard one to say. This is essentially erythropoietin, and again, remember, erythropoietin's job is to stimulate our stem cells to differentiate then ultimately into red blood cells. So they differentiate first into pro-erythroblasts, which then promote the release of reticulocytes, which are immature red blood cells from the bone marrow, and then that ultimately that stimuli will ultimately initiate the formation of hemoglobin. So erythropoietin is important, and if somebody has, like, for example, if they have kidney disease, they're not going to be making erythropoietin potentially or releasing it, and in those patients you might need to supplement. There's of course a whole bunch of different side effects. The biggest side effect is probably going to be with iron, and that's going to be headaches and GI symptoms. Probably one of the most common ones is potentially stomach upset and or constipation, which can be difficult to overcome. So that's something to think about with iron. The other thing we have to be very cautious of with iron is that overdoses in children can be really dangerous and potentially lethal. So you always have to make sure if you have any iron containing supplements or if somebody's been treating with iron, that they're keeping away from their kids. This is a picture, this is normal on the left side, and this is a picture of microcytic hypochromic anemia, which is the most common. Most of the time it's due to an iron deficiency, or it's just due to accelerated blood loss. More common in women, of course, because of menstruation, especially if they have heavy menstrual flows. Going back to this B12 bit for a minute, one thing that sometimes we forget about B12 is that in order for us to absorb B12 absorption doesn't happen until the terminal ileum, which you can see in that picture. So the last little bit of the small intestine is where we absorb our B12. And in order to absorb B12, we have to have it available, and B, we also have to have intrinsic factor. And intrinsic factor is produced in the stomach by the parietal cells. So the stomach produces the intrinsic factor, and that kind of happens in the antrum of the stomach primarily, and then the intrinsic factor and the B12 stay in the GI tract until they get to the terminal ileum, and that's where the B12 is absorbed, right? So it gets absorbed into the blood. It can be used then to, facilitate the growth of cells like we talked about and all that DNA stuff. And you can also store a fair amount of it in the liver. You can see on that slide there we store B12 for a couple years, somewhere in the neighborhood of we have essentially a 3 to 5 year supply. So that's something to think about with some of our patients that have gastric pathology, or maybe they've had a portion of their stomach removed. That also would be something we'd want to be on the lookout for, would be for a B12 deficiency. Okay, so I want to switch gears for a minute, and I want to talk about some other types of drugs to treat blood disorders. So in addition to anemia, so we already talked about erythropoietin here, which essentially is responsible for the differentiation of and formation of reticulocytes and hemoglobin formation. But we have other types of hematopoietic stem cells, right? We have the megakaryoblast, which generally are what give rise to the platelets. And then we have our leukocyte stem cells, which usually give rise to either the macrophages or the granulocytes when they're differentiating. So you can see that we have some interventions here. So we talked about erythropoietin, but colony stimulating factors are what's going to determine whether or not we are going to release macrophages and or granulocytes. The granulocytes are the white blood cells with the speckles in them. And then, of course, we have the platelets, and then there's a whole lymphocyte stem cell as well, which is not on that picture. So a couple other things to think about when we think about drugs to treat blood disorders and other hematopoietic agents. Those are drugs that we use to treat neutropenia, which is a frank deficiency in white blood cells. So if you recall, the white blood cells that are circulating in the highest concentration under normal circumstances are the neutrophils or the phagocytes, and they sort of roam around, and when they leave the blood, they migrate into the tissue, and they can eat up some stuff there, much like the macrophages, but the neutrophils are there first, and they tend to have a shorter lifespan. So if somebody has a deficiency in white blood cells, it would most likely be neutrophils, because the other white blood cells are found in pretty small amounts under normal circumstances. So these drugs are most oftentimes used with chemotherapy patients, because chemotherapeutic agents are known to suppress white blood cell production. So what they do is these drugs can stimulate the granulocyte production in the marrow, like we just saw in the picture, to increase the neutrophil counts and also hopefully decrease the time in which that person is neutropenic. And the danger around neutropenia is, of course, these cells are our second line of defense for our immune system. And so you need to have adequate neutrophils in order to ward off any potential pathogens. So oftentimes, most oftentimes I should say, these drugs are going to be used prophylactically with cancer patients to reduce the risk of neutropenia after they've either had after they've had chemotherapy or after they've had a bone marrow transplant. So there's a couple different groups, and I just want you to be aware of them. You don't need to know about these in any detail at all. But one group are called the myeloid growth factors, or the granulocytes colony stimulating factors. We saw that on the picture before. Oftentimes they are abbreviated GCSF. Filgrastim and pegfilgrastim are probably the most commonly used. They've been around and they're used frequently. We have granulocyte and macrophage colony stimulating factors. You see the name of one of those. Of course, those are going to, kind of push things down more towards the macrophage way. And then you can see, usually these are given until the neutrophil count comes up. And where your targets are going to be somewhere between 5,000 and 10,000 weight neutrophils per microliter of blood. The most common adverse effect, and there's quite a few adverse effects of these drugs, but the most common one is bone pain. So the last thing I want to talk about here are drugs that affect blood coagulation. And for our purposes in this class, I just want you to kind of know what these terms are and just have very basic information about these types of agents. So they are going to treat bleeding disorders, and that's what hemostasis means there. So there's 3 categories, and I would like you to know what these names of these categories are and what they do in general. The first are hemostatics. What hemostatics are going to do is they're going to stop bleeding. So they're going to they're going to quicken or shorten the duration of time that it takes for blood to clot. So if someone's bleeding and you need them to stop bleeding, a hemostatic would be the agent. Anticoagulants are going to slow blood clotting. So hemostatics are going to make the blood clot. Anticoagulants ideally are going to slow blood clotting, or more oftentimes they're used prophylactically to prevent the blood from clotting in people that were at a higher risk for clotting. And then thrombolytics are used to dissolve clots that have already formed. So those are 3 big differences. One's going to make blood clot, the hemostatics. Anticoagulants are going to slow clotting or ideally prevent blood from clotting. And thrombolytics are after you already have a clot, you can dissolve them. The term thrombosis just essentially means an unwanted clot within a blood vessel, and this is the most common bleeding disorder, is thrombosis. Thrombotic disorders are going to include anything that puts somebody at a higher risk for clotting. So big people that have just had a heart attack, acute myocardial infarction, the risk goes way up for those patients because of the damage to the heart wall and the mobility of the heart. So those people, if someone's had a heart attack, they're most likely going to get put on an anticoagulant. People who have deep vein thrombosis or are at risk for deep vein thrombosis because they've had a surgical procedure and they're stationary and they can't really move around, those kinds of things. A pulmonary embolism is a clot in the lungs. That would be a thrombotic disorder. Acute ischemic stroke there's 2 types of strokes. There's strokes that are due to bleeding and strokes that are due to clotting. The ones that are due to clotting are more common, and that's what's referenced on the slide there. So all those conditions, acute MI, deep vein thrombosis, pulmonary embolism, acute ischemic stroke, those drugs are going to be treated with those conditions, I should say, those people who have those conditions are going to be treated with drugs like anticoagulants or fibrinolytics, which are drugs that dissolve the fibrin, which essentially takes apart the clot. The disorders that result from the failure to clot are much less common. They're oftentimes genetic, like of course hemophilia, because hemophilia is kind of the classic clotting or bleeding disorder. But there's also other clotting disorders as well, genetic or other genetic disorders that can cause an inefficiency of clotting. And then another thing to think about is vitamin K deficiency. And so people who have liver disease oftentimes are deficient in vitamin K. And so that would be another person to think about. So here's just how a clot forms, as I'm sure you know. In this picture, we're seeing an injury and then the vessel spasms. And then with the injury, you get disruption to the endothelium there. And oftentimes collagen fibers will be exposed, and when the collagen fibers are exposed, that's one of the stimuli for the release and the call of more clotting factors there. And also platelets start migrating, and the more platelets migrate, and then they sort of tend to start sticking together, and they form what we call a platelet plug. And then the formation of insoluble fibrin kind of gets in there and sort of sews up that clot, right? Sews up that hole and makes it a nice, occlusion, and therefore the bleeding, they don't bleed at that point anymore. So this is how blood clots. Here's a little picture showing us that again. I'm sure at some point you've had to memorize the clotting cascade. Not so much now. So here's one of the things. This is kind of complex how this all happens, but here's sort of an abbreviated version. So we've got platelets and we've got platelets and damaged cells, which then kind of set off the injury, sets off the clotting cascade, starting with factor X. Don't need to remember that. But that will ultimately lead to the activation of something called prothrombinase, which is an enzyme that essentially is going to facilitate the conversion of prothrombin to thrombin. You need vitamin K to get here. Prothrombin to thrombin. Thrombin then is able to convert fibrinogen into fibrin, and that's what allows this to happen, and that happens in the blood. So it's pretty interesting. So if somebody is at risk for clotting, then you might want to inhibit this at some point. And so that's essentially what the anticoagulants do by some mechanism, and there's a lot of them. So some of the, so all anticoagulants are going to slow down blood clotting. So you're going to think about these in patients that are at high risk for clotting, not that already have a clot. If they already have a clot, then we're going to want to go a little bit stronger and actually dissolve that clot. But with a thrombolytic agent. But anticoagulants are usually, like I said, they're usually used more prophylactically. Some examples of anticoagulants are heparin, a lot of the coumarin derivatives. These guys are used a lot. One thing that's notable about the coumarin and the coumarin derivatives are they are highly plasma protein bound, right? They affect the cytochrome P450 system, so we know a little bit about that. So we kind of have to think about that plasma protein business. Oftentimes you're needing to give a big loading dose for these patients in order to make sure that they have enough drug available. And then you can slow the dose down. And then we also have to think about interactions with other drugs that are protein bound as well, because what we don't want to do is dump a whole bunch of anticoagulant into the blood if the plasma proteins decide they want to grab onto something else. Aspirin is an anticoagulant, it's an antiplatelet aggregator. So these all work kind of like different mechanisms, which we're not going to be able to get into. Dipyridamole is another one. Pentoxyphylline is another one. So these are all examples of anticoagulants. One thing to note is that you don't want to substitute either ibuprofen or the COX-2 inhibitors for aspirin, because they do not have the same effect. And that is something to note. Like most people know that they can take an aspirin if they're worried about, heart attacks and or strokes. Mostly strokes is why they should be doing it. But they don't oftentimes know that ibuprofen is not the same. It doesn't have the same action. It's not an antiplatelet aggregator at all. So here's kind of a summary of what I just said. So here's just some, we already talked about these on the previous slide, but these are therapeutic uses for anticoagulants. Again, anybody who has at risk of clotting. So stagnant blood flow, venous thrombosis, to prevent coronary thrombosis, especially if they're at high risk. So if they we already know they have atherosclerosis, atrial fibrillation and or any kind of cardiovascular heart valve disorder, those disorders they're quite common, and they also really increase the risk of clotting. So those patients are put on anticoagulants also prophylactically. It kind of makes sense, but you sort of have to, they're more prone to bleed, these people, right? Because they're on anticoagulants, they're not going to clot as well. So you kind of have to watch for that, right? They can bleed from all over the place if they're on an anticoagulant, and that can be pretty acute. You can see, and GI bleeds are a challenging one because oftentimes we don't know about GI bleeds. So if they have ulceration and they bleed, on an anticoagulant, they're going to be more likely to bleed. And you can see about a quarter of deaths are due to GI bleeding, which is crazy. So again, so you're going to be real careful with people with bleeding tendencies, obviously, if they've got any kind of ulceration or cancer of the GI tract. Not really a good idea to use these in pregnancy. There's one kind of anticoagulant that you can use in pregnancy with some degree of safety, but most of the time we're not going to want to use them because it really increases the risk of abortion. If they have severe liver or kidney disease, we don't want to use anticoagulants if we can help it. You don't want to give the anticoagulants IM because the muscle is just too vascular and it can cause a really big hematoma, a really big bleed. And there's a whole bunch of drug interactions with these, and they can be pretty serious. So we gotta be cautious, right? And especially when we think about plasma protein binding, right? There's a couple that notable, phenobarbital, which we oftentimes use for epilepsy, increases the way the liver deactivates the anticoagulant. So oftentimes the anticoagulant is not as effective. A drug for gout called phenylbutazone displaces the anticoagulant from the plasma protein, and so that would increase the anticoagulant nature, so increase their risk for bleeding. It's a good idea for anyone on anticoagulants to have a med alert so people know if they've had an accident of some sort that they are going to potentially be bleeding much more profusely than somebody who would not be on an anticoagulant. So let's finish up with talking about dissolving clots now. So we've talked about stopping bleeding, we've talked about retarding clotting, and now finally clot resolution. So after a clot has been formed and we've had some healing, then we have thrombolytics that can activate plasminogen, and plasminogen essentially is going to cause plasmin to break apart the fibrin and the fibrinogen. And essentially from there we would produce products that would inhibit further coagulation. So we start dissolving the clot and inhibit further coagulation. So thrombolytic drugs, and you can see there's a bunch of them up there just in case you're familiar with some of them, streptokinase, urokinase, etc. These are just examples. You don't need to know the names. Who you'd want to give a thrombolytic drug to, again, is somebody that you know has a clot. So they've got a clot. They're not at risk for clotting. They actually have a clot and you need to dissolve that clot. So again, an acute pulmonary embolism, if they've got a clot that's in their coronary arteries. Some strokes, the ones that are due to clots, not the ones that are due to bleeds, that would be disastrous if you gave them a thrombolytic agent. DVTs. So again, you want to be very careful with people who have acting bleeding tendencies, right? Because if they have clots anywhere, they're going to be dissolved, right? You want to make sure that they have not had a cerebral vascular accident anytime recently, 2 hours or older or even more, a little more. So a CVA is a no-no with thrombolytics, again, because you don't know if they have any clots and you don't necessarily want to cause them to bleed into their brain. You don't want to do that. I can say that with certainty. People who have active tumors, you want to be very careful with these drugs. And again, surgery and childbirth is, especially within the last few months, this can be detrimental because there are going to be, they've had surgery and or childbirth, so chances are they have some clots that have not completely been resolved, and then these drugs could come in and really cause them to bleed. Anaphylaxis is not super common, but it's a possibility, so it's something to sort of watch for with these drugs. So for our class, I'd like you, again, this is the very basic here. I want you to know what the difference is between a anticoagulant, a thrombolytic, and a hemostatic, and then just some common sense around these, which ones you're going to use for bleeders, which ones to use prophylactically to prevent clots, and which ones to use for people who already have clots. And then just the very basics on anemia and the hematopoietics, knowing what kinds of anemia they have and how to sort of approach each one of those, iron, B12, folic acid, blood builders, etc. Okay, that's it for this one. We will come back for more at a later date. See you later.